Peace. Welcome. Welcome, YouTube. What's going on, y'all? It's time for the YouTube live book reading of Clinical Application of Respiratory Care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. Second edition. Here we go. Episode 57. We pick up at the bottom of page 331. Peace. Welcome, YouTube. Peace, peace. All right. Let's go. We're in chapter 22. Indications for mechanical support of ventilation. It would be futile to categorize indications for mechanical support of ventilation by disease entity. Not only would this result in endless lists, but with each disease, it would have to be stated that it is not the disease itself that necessitates the ventilator, but rather the degree to which the disease's physiologic stress impinges upon cardiopulmonary reserves. The clinical indications for commitment to a ventilator are best stated in terms of cardiopulmonary pathophysiology. There are four such categories that have universal application in the clinical setting. 1. Apnea. 2. Acute ventilatory failure, acute respiratory acidosis. 3. Impending acute ventilatory failure. And 4. Oxygenation. Apnea. Definition. So if we're writing and taking notes for all those in the playlist, I'll put it in the vocabulary as well in the description. Thank you so much, all the book lovers community. Highest heart love to all the book readers and lovers. Apnea. Absence of spontaneous ventilation necessitates mechanical support of ventilation. Acute ventilatory failure. Acute respiratory acidosis. The patient's minute ventilation may have little correlation with his effective physiologic ventilation. Inadequate alveolar ventilation may be due to an increased physiologic dead space, in which case the patient usually has an increased minute ventilation. Therefore, simple clinical observation or measurement of minute ventilation does not necessarily reflect the adequacy of physiologic ventilation. Assessment of the adequacy of physiologic ventilation can be accomplished only by blood gas analysis. Inadequate alveolar ventilation, arterial carbon dioxide above an acceptable limit, reflects a failure to adequately remove carbon dioxide by the lungs. When such a ventilatory failure is accompanied by acidemia, arterial pH below an acceptable limit, the failure must be of recent origin, acute, and therefore a direct threat to cardiopulmonary homeostasis. Thus, an increased arterial PCO2 with a decreased pH is acute ventilatory failure, acute respiratory acidosis. In such a circumstance, mechanical support of ventilation is indicated unless some other effective treatment is immediately available. Impending acute ventilatory failure. Clinical assessment of the work of breathing, the pathogenesis of the disease process, and the patient's cardiopulmonary reserves may be may result in the clinical judgment that acute ventilatory failure is inevitable or extremely probable. This is sometimes referred to as the patient tiring or fatiguing. This is often a debatable and unclear clinical problem necessitating careful monitoring and sound clinical judgment. It can be most classically documented when sequential blood gas analysis reveals consistently increasing PCO2 and decreasing pH values. Oxygenation, bottom of page 332. Look at that. Oxygenation. When the patient is breathing room air, hypoxemia will be present with apnea, acute ventilatory failure, and usually impending acute ventilatory failure. In fact, most ventilatory problems are accompanied by poor arterial oxygenation. However, restoration of adequate physiologic ventilation usually improves the hypoxemia and thereby enhances tissue oxygenation. With modern capabilities of airway pressure support, oxygen therapy, and intravenous fluid therapy, it is no longer reasonable to consider most primary oxygenation deficits as indications for ventilators. Most primary oxygenation deficits are best supported by oxygen therapy, cardiovascular support, PEEP or PEEP therapy, bronchial hygiene therapy, or combinations of these techniques. There you go. Although any of these may be administered in conjunction with the ventilator, none of them requires the use of a ventilator. Thus, modern indications for ventilatory support do not include most primary oxygenation deficits unless they are directly attributable to a deleterious work of breathing or ventilatory breathing or ventilatory pattern. If oxygenation may be improved by decreasing the work of breathing, or if cardiac function may be improved by decreasing the work of breathing, a ventilator may directly improve the oxygenation status. Peace, highest heart low. Welcome to all the book lovers and book lovers community. We're here reading live from the light. Thank you for likes and subs. Peace to all my family and friends. Thank you so much. Yes, clinical application of respiratory care. We're in the 22nd chapter. This is 1979 Medical Publishers Association. All right, here we go. Summary. Page in the middle of page 333. Summary. It is essential for the physician and the respiratory care practitioner to have a clear understanding of both the indication for commitment to mechanical ventilation and the working diagnosis of the potentially reversible process. Appropriate maintenance and discontinuance of ventilator care may be accomplished only in the context of clear cut criteria for commitment. For example, if a patient has been placed on a ventilator for apnea, it is obvious that when the patient begins to make ventilatory efforts, the need for the ventilator must be reevaluated. On the other hand, if a patient is placed on a ventilator for acute or impending acute ventilatory failure, he or she is usually breathing quite actively at the time of commitment. In such circumstance, efforts to breathe while on the ventilator should not be necessarily interpreted as signs for reevaluation of the need for ventilator support. Modern ventilator care demands clear cut clinical goals, clear cut indications, and a thorough knowledge of the cardiopulmonary pathophysiologic process. Under these circumstances, safe and intelligent commitment may be undertaken. The 5 steps of ventilator commitment. Bottom of page 333 for all those reading along and in the playlist. Thank you so much. Presentation of the following material is meant as a guideline for the respiratory care practitioner in the process of ventilator commitment. It is meant to be neither an exclusive, dogmatic statement nor a complete list of all possibilities. The authors believe that if the following steps are used as a general guideline, they will serve well in safe and orderly conduct of ventilator commitment. Step 1. Establish the airway and manually support ventilation. There you go. If you're writing down, taking notes. Establish the airway and manually support ventilation. The safe establishment of an artificial airway to facilitate the support of ventilation and protect the lungs from aspiration of foreign substance is the first and most important factor in ventilator commitment. The respiratory care practitioner must be capable of assisting the physician in appropriate airway establishment and able to assume responsibility for ventilation once the airway is established. Initial support of ventilation should be accomplished by manual ventilation. A self-inflating bag with a tone one-way valve system is appropriate. Most commercially available manual ventilators have capacities of approximately 1.5 to 2 liters and will deliver approximately 40 to 80% oxygen concentrations when connected to oxygen sources. Manual ventilation offers the advantages that 1. It is immediately available. 2. It can be easily varied from moment to moment to meet the patient's demands. 3. It is reasonably free of technical and mechanical complexities. 4. It offers the clinician direct moment to moment contact with airway patency, system compliance, and patient effort. Thank you so much, YouTube. Thank you for the likes and subs. Thank you for being here and reading with us. Oh, peace. Eyes Muhammad. Hi is heart love. Mia Mia. Bismillah. Step 2. Cardiovascular stabilization. Establishment of the airway and institution of positive pressure ventilation in a critically ill patient may initially add to cardiovascular instability, hypotension, and arrhythmia. Too often, hypotension following the establishment of an airway and positive pressure ventilation is assumed to be due to such factors as 1. Stress of intubation. 2. Delay in accomplishing successful intubation. 3. Pharmacologic agents used to facilitate intubation, e.g., muscle paralyzants, narcotics, and 4. Inappropriate support of ventilation. Although any of these factors are possible, especially when improperly applied, hypotension often occurs when none of these factors is present and in spite of the highest degree of skill. Most often, hypotension and arrhythmia are secondary to either one, decreased sympathetic tone, and two, decreased venous return, or three, a combination of these factors. Bottom of page 334. Decreased sympathetic tone. The autonomic nervous system in a patient requiring ventilator commitment is usually experiencing significant stimulation, hypoxemia, hypercarbia, acidemia, while attempting to maintain cardiopulmonary homeostasis. Ding! Whew. Again. That's why we come here to this peaceful place in YouTube where we read books and learn from masters because we just get beautiful solutions, right? Peace, Katrine. Oh, my love. It's been very interesting. Thank you so much for reading with us. There's a big pin drop. You see, we got another solution. Man, highest heart love. Thank you so much. You see that though, right? After all the stress of intubation, the most often hypotension and arrhythmia are secondary to either decreased sympathetic tone, decreased venous return, and a combination of these factors. And then we go into decreased sympathetic tone. The autonomic nervous system in a patient requiring ventilator commitment is usually experiencing significant stimulation, e.g., hypoxemia, hypercarbia, acidemia, while attempting to maintain cardiopulmonary homeostasis. In conscious patients, the physiologic stress is usually compounded by a state of anxiety and fear. These factors result in a significant degree of arterial and venous constriction, as well as myocardial stimulation, since support of ventilation usually relieves the work of breathing and significantly reverses hypercarbia, acidemia, and hypoxemia. The patient relaxes and may enter a state of sleep for several hours. Also, it is not uncommon for a state of consciousness to be induced pharmacologically. Right, eyes? Peace, Muhammad. He said, nice. Thank you so much. Oh, man. Eyes, heart, love. Salam alaikum. All right. Here we go. Page 335. The combination of loss of consciousness, relief of work of breathing, and improved ventilation and oxygenation often leads to a profound and sudden decrease in sympathetic stimulation to the cardiovascular system. This decrease in sympathetic tone often results in arteriolar and venous relaxation, leading to a rapid and significant increase in the vascular space. The sudden relative hypovolemia may not be immediately compensated because the patient is unable to mobilize extravascular fluid rapidly. In addition, the relative hypovolemia is significant because the Intrathoracic positive pressure created by the ventilator accentuates interference with venous systems. Woo! Super high level. Oh my goodness, I love it. It makes so much sense when we put together all the dots, right? That's why this peaceful part of YouTube is always going to be useful. You can go back through the playlist and you can read books about water, about anthropology, about animals, about energies. Oh my goodness. Anatomy, right? Respiratory care. Wow. All right, here we go. The middle of page 335. Thank you so much. I'm Master Uriel Riley, Master Fitness Trainer, and your moderator on this channel. Thank you so much. Decreased venous return. Most patients committed to ventilator care have limited cardiopulmonary reserves. The combination of relative hypovolemia and positive pressure ventilation often results in hypotension. This should be anticipated and dealt with rapidly and efficiently. It is imperative to be aware of the potential for hypotension following the establishment of positive pressure ventilation. The cardiovascular system is primarily stabilized by correcting the relative hypovolemia. See Chapter 27. When hypotension is severe, the patient should immediately have both lower extremities elevated 20 to 30 degrees from the horizontal position. There we go. There we go. Ever in this position, we want to always elevate their lower extremities. Why? Yes, because the intercostal and the subcostal blood flow, we want to return that as fast as possible back to the heart. Okay, here we go. Respiratory care. Remember the gas exchange. All right. Hi, it's Heart Love. Thank you for being here. And remember, we're reading in the section of principles of ventilator care. So this is decreased venous return where we're speaking about. All right. When hypotension is severe, the patient should immediately have both lower extremities elevated from 20 to 30 degrees from the horizontal position. This is a form of autotransfusion in which lower extremity and pelvic blood drainage is facilitated by gravity. Ding! The transient increase in core blood volume should improve venous return to the heart. The eventual correction of the relative hypovolemia is accomplished by appropriate intravenous fluid administration. See Chapter 27. During this period, manual ventilation can be varied to be synchronous with the patient's efforts and allow long expiratory periods. The patient must not be allowed to fight the positive pressure and unduly increase intrathoracic pressure. Step 3. Establish appropriate monitors and baselines. Prior to commitment or as soon as possible after airway establishment and positive pressure ventilation, a cardiovascular baseline or blood pressure and pulse must be recorded and followed. An adequate intravenous line should already have been established. As soon as possible, an ECG monitor, arterial line, and other appropriate monitors should be evaluated. And step 4, establish ventilatory pattern. The patient's spontaneous breathing should initially be augmented by manual ventilation. Usually, patients will gradually relax and adopt the preferred slower and deeper positive pressure ventilatory patterns. They can be, they then, they can then be completely controlled or smoothly augmented. At this time, the mode of ventilator support must be decided upon and the anticipated machine pattern mimicked by hand ventilation. If the patient will not tolerate the anticipated pattern by manual ventilation, he or she most likely will not tolerate being placed on the machine. The transfer from manual ventilation to machine should involve as little physiologic change as possible. Peace, YouTube. Thank you so much for reading along with us. I will put the vocabulary in the description when it's finished uploading. I'm so honored. This, you guys being here. Oh, highest heart love. Thank you so much. Reading clinical application of respiratory care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. And we're in the 22nd chapter. All right, step 5. Here we go. And then we'll pause after this step. Connection to the ventilator. This is the last step. A ventilator is for maintenance. Emphasis must be placed on the fact that commitment to positive pressure ventilation involves preparing the patient for the machine. Throughout all of ventilator care, the respiratory care practitioner must remember that whenever there is instability or mechanical problems, the patient should be manually ventilated. Thus, once the patient is connected to the mechanical ventilator, the process of ventilator maintenance has begun. And we'll pause right here. When we reconvene with clinical application of respiratory care, we will pick up in the middle of page 336. Thank you so much. Wow. Look, we did it again. And I told you, this chapter is one of the longer chapters in the book. So we will be in here for a couple readings, at least. Not like the last few. Thank you so much for being here and reading with us. Highest heart love to all the honorable light workers doing the work. This said something else. Highest heart love. Peace. Peace, Queen Goddess. Highest heart love. And when we reconvene in chapter 22 of Clinical Application of Respiratory Care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. Shaking it up on YouTube, reading books, right? Do it. Much love. Highest heart love to all the book readers out there, the book writers, all those aspiring rep techs and, M-techs and OR techs, nurses of all kinds. You are all healers, doctors of all kinds. We just honor you on this channel. Thank you so much for being a part of the Lightworkers community. Highest heart love. Much love to every single one of you. I will see you soon, right? When we reconvene. Let's have a glass of love water. All right. Love to all our friends and family. We're pushing towards 600 subs, reading books on this peaceful part of YouTube. We read books and learn from masters. Cheers. All our friends and family. Hi, it's Heart Love. Peace. Happy Friday. What's going on? Peace, Deep Green. Another light worker in the building. We love you. We love all the yogis, right? All of you that honor the Most High and let that light shine through you. Tomorrow we have a ribbon cutting. Yes, cheers. I love you. Here we go. Love water to the people. Mm. Oh, that's so good. I love you. I love you. I love you. I love you. Thank you so much, Deep Green. Peace, peace. All right. I will see you soon when we reconvene in chapter 22. All right. I love you. I love you. You know, that's what this peaceful part of YouTube is for. Love on one another, uplift the people, give them information so they can heal themselves, we can heal ourselves, we can heal others. We can master ourselves. We harmonize with others and our environment. So love and peace and harmony. I'll see you soon. Peace, peace. Love you. Yes. Oh, much love to you too, Deep Green. Peace, peace. Oh, crown shot. Yes, that's right. You know it. 1,000 points of light. That's why we keep the crystals around, right? We got it. We are the crystal, right? And so we harmonize. Peace, peace.